Next speaker, it gives me immense pleasure to introduce to you all Dr. Natesh Prabu. He has been my teacher also, and we can safely say he's an authority in fluid therapy in critically ill. He's an associate professor from Department of Critical Care Medicine, St. John's, Bangalore. His special areas of interest is hemodynamic monitoring. In fact, it is a proud moment to tell that he was part of the original research of tidal volume challenge along with Professor Sheila and Professor JLT. So he's actively involved in critical care education, simulation-based training, mechanical ventilation, critical care nephrology are his core areas of interest. He has almost 40 publications to his name, including chapters, articles and editorials. He's been faculty at many national conferences of ISCCM, Best of Brussels, Critical Care Sonography and Hemodynamic Monitoring. Over to you, sir. Thank you.
At the outset, I thank the organizers to having me, and thank you, Dr. Suma, for a nice introduction. So, over to the topic of fluid therapy in critically ill. It's quite a vast topic, and it's been there for ages, a lot of controversies. Still, we don't know many solutions for a lot of questions. So I'll take you through a little bit of concepts. And the major thing is how to translate the evidence available to the clinical practice to knowing the physiology at the background. So that gives extremely good information how to use the fluid with what dose at the correct time and how to monitor it. So I'll take you through a little bit of a review of quick physiology of fluid therapy. And what are the phases of resuscitation and how the fluids has been used in different phases of resuscitation, and short case-based discussion while I actually discuss. So first of all, why to give fluids? It doesn't mean that patient comes to ICU, everyone requires a fluid. There should be some kind of a rationale behind why actually we are giving fluids. The major goal is to maintain the tissue perfusion. That means the perfusion should be good enough so that organ function actually continues. Second thing is to maintain the electrolyte balance as well as the acid-base hemostasis. And final one is nothing but to maintain the normoglycemia. These are the common goals described in literature so that the fluid is chosen. But which fluid? Are you resuscitating a patient? That means the patient is having a severe hypotension and shock. Is the priority is to resuscitate the patient, or the patient is just not taking anything, maybe a complex post-surgical patient. So for the purpose, have you choosing the fluid, or is a different purpose like resuscitation and maintenance predominantly as a replacement, like a patient has come with a severe volume deficit like a cholera, patient comes to a diarrhea, or maybe a patient having increased drain, vomiting, excess diuresis, etc. And what is the purpose? Depending upon the purpose, actually you have to choose the fluid and you have to give. So if you are choosing a fluid and actually infusing the fluid to the patient, what happens? It gets distributed to the different volumes. Like some goes into intracellular, some goes to extracellular, some only retains in the vascular compartment. Depending upon the purpose, we have to choose the fluid. For example, to give an example, if you are infusing 1 liter of crystalloid, to give an example, any isotonic fluid like a normal saline, ringal lactate, balanced salt, so what will happen? It will get distributed predominantly in the extravascular space and only 1/3 remains in the vascular compartment. In comparison, if you give a colloid, what will happen? Actually, it stays in your vascular compartment predominantly. But when you come to the critically ill patients where they have a severe inflammatory response, sepsis, massive trauma, burns, etc., what will happen? There will be a severe endothelial injury. So there will be a lot of damages to glycocalyx will be there. So it increases permeability. So in a normal state, when you give colloid, what will happen? Because of hyper-oncotic pressure in the vascular compartment, it pulls the fluid from the interstitial place as well as from the cell. So you are actually maintaining the volume in compensation to the dehydration happening in your cells. That's not good. But what happens in critically ill state? The vessel is not actually intact. There is a breakage, there is a permeability. So these colloid particles come outside your interstitial space, it pulls fluid into the interstitial space rather than your vascular compartment. So in a way, if you give just a water, like a plain dextrose, it usually gets evenly distributed into the cells and in the interstitial compartment, very, very, very less in the vascular compartment. That means when any other severe dehydration, heat strokes, hypernatremia, you need fluid that goes into the cell. That's where actually you choose a dextrose containing fluids or probably half normal saline where it has a predominant water. So these are the principles behind choosing different fluids. I will take you through a simple conceptual model where a patient is coming with a shock or maybe hypotension to the casualty. Here if you see different shock. So during a shock, what happens? There is an intravascular deficit. So your actually volume, if you see, it is actually even lower levels till the patient recovers back. So we divide this phase into 4 components. One is a phase salvage. That means you are trying to salvage a patient, life-threatening situations. So your prime priority is to get a quick hemodynamic stability. So once you become hemodynamic stable, next you are going to see what are the organs they are not working properly, trying to support the organs. That becomes the next phase we call as optimization phase. Next comes your stabilization phase, where actually patient decently stabilized, may not require much fluids. You have to judge whether to give a little bit of fluids or whether to stop fluids. This is the time actually you have to judge. Last is patient is exactly recovered back, where you have to try to remove what the fluids you are given. So we call as actually evacuation or a de-escalation phase. So depending upon these phases, actually we'll know how to titrate fluids, when to give, at what dosages, which fluid to choose. So to give a quick example, patient actually with a AML who has a chemotherapy, who comes with the loose motions. Commonly it's used to have a enterocolitis, or maybe just because of a chemotherapy induced mucosal damage, they may have a diarrhea. Such patient was come to casualty is actually predominantly hypotensive, peripheries are very cold, patient having basal crepitations and diffuse tender abdomen is quite septic here. If you see ABG patients having high lactates with a kind of acidosis, this is a common presentation. Here if you see, it's a life-threatening situation where having extremely low blood pressure with high lactates. So this is a situation we resuscitate the patient. So the choice of fluid actually we are going to give, it should achieve hemodynamic instability in a faster rate. Rapid and achievement of hemodynamic stability. For that, you should choose a fluid that remains in the intravascular compartment. So depending upon which fluid that stays in the vascular compartment, that kind of fluid you have to choose. So actually, decently, both crystalloids and colloids stays in the vascular compartment. Which one to choose? It is a ever-ending debate, but this is the study that came in between. The debate was quite high, but it was little pro-colloids in terms of achieving hemodynamic stability faster. That means faster you achieve, lesser the shock duration, and better the outcome. But several studies, large studies, this is an important study, just study 7,000 critically ill patients, multi-center randomized controlled trial. It didn't prove any difference between a crystalloid or a colloid, but in turn, it had shown extremely high renal injury and many patients land up in a dialysis. So like slowly we move from pentastarch to Voluban and 6% to 0.4 equation, slowly moved on, but none of the starches shown any benefit, but it has led to much harm. So almost we are not at all using any starches in our ICU. So in replacement, sometimes we use colloids based on these 2 studies. One is a safe study, even though it is safe, but actually it's not safe for a patient with a traumatic brain injury. Why? Because they use 4% albumin. Actually, it is a little hypoosmotic. That's the reason actually it led to more cerebral demand, more death. Then this is a study, albeo study. Even though it didn't show any difference between crystalloid and colloids, they give 20% albumin. With subgroup analysis, it's much safer for septic patients. So nowadays, if you want to give a colloid, that in a very narrow population, we just give albumin. So next the debate started with a balanced crystalloid versus a normal saline. So a lot of studies, this is the first study that actually started, and the split trial, it didn't show any benefit or a harm. So even though there is no benefit versus a normal saline, and it didn't show more injury with a normal saline as well. Next comes an important SMART study. This is a breakthrough study in a critical care, and they compare balanced salt versus saline. The only problem is they included even ringer lactate also. That even though it's not actually a balanced one, so but still that idea was to get whether it is more injurious, chloride is more injurious or not. So only they kept a major AK as one of their important outcome. So, but they didn't find any difference. Next 2 important trials that came. One is a basics trial, other is a plus trial. It is like exactly balanced. Like they use plasma light, and other is normal saline. So they didn't find any difference in any of the outcome. The important thing, it is from Brazil. It is almost like our country population, the resource limitation, everything is almost same. So this study didn't actually show any difference outcome. But if you give balanced salt in a traumatic brain injury, it was more deteriorous. So it's as equal as giving a normal saline to any patient to come to your emergency or ICU. Similarly, next study that's come just a couple of years before, similar results. So just choosing a fluid, I still feel ringal lactate and normal saline is good enough. Not to go towards balanced crystalloid, pending a much lesser evidence. And to try to avoid all starters and be safe. How much to give, how to monitor. So dosing fluid is always a different ball game. It started 2012 where they used protocolized. Now actually we are not using this protocolized one that is proposed by Rivers et al. By and almost 2 decades ago. Then sepsis camp again they turned 2012, 16, 20, 21, but still they retain their same 3 hours with 30 mils per kg. Still they retain within 3 hours at least 30 mils per kg, but problem is doesn't have any strong evidence for this. Still, if the resource limited setting, at least you give it so the patients are safe. But we commonly monitor and try to see whether fluids are beneficial or not. So this is the next phase once you finish resuscitation. So like life-threatening situation to organ support, where you try to optimize these patients. For example, our patient was having hypotension. Now our patient is intubated, ventilated. His still peripheries are cold, lactates are high. Still there are signs of tissue hypertension still persisting, but his blood pressure is decently good enough with an ORAD support. But here actually nothing is going to happen immediately to his life, but organs may go down. Kidneys, liver, and brain may go down. So it's very important. So here, whether to give more fluids or not is my one question. When to stop this fluid? These are 2 questions I'll ask during this phase. So to answer this question, first thing is patient should have signs of shock, number 1. And he should be responding to fluids, and there should be safety. How to know if the patient is going to be fluid responsive or not? If without judging it, if you just transfuse fluids, what will happen? We will be land up in complication without any benefit. So staying balanced is easy to tell, but it's very, very difficult to achieve. So it's important to predict who will respond to fluids. For that, actually, we have a lot of tests. One of the tests, actually, we devised is a tidal volume challenge test, especially in a population with a low tidal volume, the ARDS population. Just use a pulse pressure variation. So, like, so many tests are available. One of the tests we can use, we can predict. If it is successful, you give fluids. If it is dangerous, please don't give fluids. Next, we'll move to the phase. Here, the major thing is, rather than giving more fluids, my question is, can we stop giving fluids? So that's the thing actually I will ask. Here, my patient is actually hemodynamically stable, but no NORAD support, well and good. But actually still having a lot of large volume motions, fluid loss is happening. That means I need to give some kind of fluids, but not in a very large quantity. But in the back of mind, I know some fluids has to be given, how to give it. Final one, if the patient gets completely stabilized, the recovery phase, patient is decently good, urine output is well, cumulative balance is very high. That's where actually I will ask, can I start removing these fluids? If I started removing fluids, when to stop removing? These are the 2 questions actually I will ask during this time. So the removal can happen spontaneous. Patient is actually a good person where actually he can diurese on its own when he's having recovery. Or sometimes we just help of a diuretic will give. Rarely we use albumin because it keeps the volume inside the vascular compartment, helps kidney for a better perfusion. Along with the diuretic, it may be very easy. So these are the actually things that are actually very useful when you think resuscitation. These are the phases, how to use fluids, how to dose it, what are the situations where actually we think stop fluids and evacuation. Next comes a different ball game of a replacement fluids. That means patient is already lost. He had a multiple diarrhea before he has come, but you may not know how much he has lost. That is a big deal. So match the lost fluid. If you don't know which fluid is lost, you may not know how to replace it. So depending upon the patient's symptomatology, excessive vomiting, or maybe pancreatic fistula, maybe excessive diuresis, diarrhea, so you know which fluid is lost. Try to choose a fluid that has almost similar electrolyte as well as water composition. Try to use it, but the amount is little more arbitrary. So coming to final one, maintenance fluids, it's nothing but day-to-day maintenance of your body systems. Further, actually, we have a lot of principles involved. One, you have to prevent dehydration and electrolyte imbalance. If this is the goal, that means which fluid you should use. So you should use a fluid that has enough water and electrolytes. Second thing is, similarly, you should prevent ketosis and you should prevent your glucose and proteins from breaking down. Because your patient is not having any calories now, he is just NPM, but he requires, for this you need dextrose. That means when a patient is having NPM, not taking anything, you want to choose a fluid that has enough water, enough electrolytes, as well as provide dextrose. That means it should be a combination of dextrose containing fluids with water and electrolytes. So when a patient is not taking or maybe having post-op situations and partial feeds, this kind of situation we choose one of these fluids. So these are the formulas available. Commonly we go with 1 ml per kg. This will take, slowly will transfuse and see. But word of caution, it can be a default fluid, but if the patient is actually having low sodium, better not go with the 0.45, better to go with DNS. Patient is having high potassium, don't add more. If the patient actually is having more loose stools, just check what fluid can be given, and no urine output, better not to give a high volume fluids. So this is the one situation. Actually, I was just thinking the same patient, so that managed by us. Here you can see that patient is still having a loose stools. What we'll do, usually we measure the diaper weight. Patients having watery motions, we measure the weight, we will know how much exactly is passing. So now patient has come with 10 liters of diarrhea. He lost it already. To replace that loss that has happened already, I'm giving a fluids, ringa lactate with potassium. It is going constantly. The idea is to give the fluid that is lost. Now he is losing here, you can see. How to replace this? We can replace with a smaller volume of same fluid, so that it won't add to the next day's loss. And this what he is taking is going to be maintenance. So maintenance, replacement, all these things can go hand in hand. Unless you measure the loss, you may not know how much to give. So this is a hypothetical what I gave. So extremely sick patients, idea is resuscitation. Second situation, same patient, not sick enough, BP is stable, he may not require even ICU admission. Here the goal is not resuscitation, it's a replacement. Same patient, good enough, just few episode diarrhea, we'll tell don't come to hospital, just take ORS. This is a kind of a fluid management for this kind of patient. So finally take home message, fluid therapy is based on resuscitation, maintenance, replacement, and it can go hand in hand. There is no actual timeline, but remember the concepts, which fluid to use. And the fluid of choice, predominantly crystalloids, never a starch. And if you want to use, and it is albumin. So we never gave only albumin, only crystalloids. Already it's a match when there is a requirement. So the studies has not addressed, you give crystalloid versus colloid plus crystalloids. The study has not done. They have done either crystalloids or colloids. So a lot of studies has to be done in this area. And thank you very much for patient listening. So I take this opportunity to invite for the critic quest what we are conducting. So one is a hemodynamic monitoring workshop, other is a communication workshop, and people who are interested can just meet me. Thank you very much.